Hello, I'm Yasser Janab, interventional cardiologist in Tehran Heart Center, presenting the topic pro-inflammatory responses in minimalist TAVI. Minimalist TAVI could be applied when we use no general anesthesia, no intraprocedural transesophageal echocardiography, and no femoral artery surgical cut-on, and we use moderate sedation, percutaneous vascular access, and only post-implant transthoracic echocardiography. Minimalist transcutaneous aortic valve implantation is more efficient than TAVI with general anesthesia with similar safety at 1 month and long term. Our case is a 70-year-old lady with history of stenting on LAD, L6, and RCA. She was known case of hypertension and complained of dyspnea and exertion function class 3. Transthoracic echocardiography showed good LV function, severe valvular aortic stenosis with moderate aortic regurgitation. CT angiography showed perimeter of 75 mm, good right coronary artery and left coronary artery heights, and only mild aortic regurgitation. We had also good access points. The patient had conscious sedation, right femoral artery managed by perclosed Broglie suture-mediated closure system. No temporary pacemaker lead was placed in right ventricle. In case of requirement of temporary pacing, left ventricular pacing via LV wire was planned. You see how the aortic valve was wired. Portico 27 was applied. We used FlexNav delivery system for Portico valve. As you can see, INOV O35 superstitive wire was used. Portico valve is a self-expandable valve. Several hours after the procedure, she had body temperature of 38.5 degrees Celsius. Peak level of CRP increased to 6.45 mg per deciliter 48 hours after the procedure. Also, platelet count decreased from 291,000 to 130,000 per microliter of blood, but there was no significant change in leukocyte count. However, the patient was discharged on day 3 after procedure with good condition. Echocardiography showed mean gradient of 10 mm of mercury with mild paravalvular leakage. Patients after surgical aortic valve replacement or TAVI exhibit a robust pro-inflammatory response. CRP elevation after TAVI should be expected to peak on day 3. An infection should be considered if CRP increases about 11 and if patients show other signs of infection. Elevated CRP at baseline and at day 3 is associated with higher 30-day mortality. There was no difference in peak CRP level following balloon expandable or self-expandable TAVI implantation or if post-dilation was required. However, when pre-TAVI balloon aortic valvuloplasty was performed, this resulted in a significant increase in the peak CRP levels. Following TAVI, a transient decrease in platelet count has been reported. Platelet count typically recovers approximately 72 hours after the procedure. The newer devices and smaller delivery systems are associated with less systemic inflammation. In summary, patients even after minimal TAVI could exhibit robust pro-inflammatory response. Thanks for your watching.